So dear colleagues, welcome. Welcome to New Perspectives in Metastatic Urothelial Carcinoma. I'm here today in this expert-to-expert interview with the world-known expert Maria Jose Juan-Fita. Hello, Maria. Nice to see you virtually.
How are you, Axel? It's my pleasure to be here today with all of you.
Yes, quite fine after recovering from ASCO just last week. So exciting data. But on the other hand, let's just start off how you treat patients with advanced metastatic urothelial carcinoma now in 2024. What is your preferred treatment? Is it a combination? Is it a monotherapy? How do you choose which patient gets which treatment?
So actually, in my patients, in my daily practice in patients with metastatic urothelial carcinoma, we can only offer them the Javelin trial schedule with platinum gemcitabine, followed in case of no progressive disease of avelumab maintenance, independently of cisplatin eligibility, because we are offering them with carboplatin gemcitabine in those with a body cough or in those with not an adequate clearance of the creatinine. The fact is that the EV Pembro are better results in terms of median overall survival, but we can talk about it later if you want.
That's almost like the same situation we have here in Germany. We want to offer EV Pembro, and this is not approved yet. As of this point of the year, we are expecting the approval. However, some weeks ago, we had EMA approval of the chemotherapy combination with nivolumab, which we have learned last year's ESMO that it also is better than just chemotherapy alone with some months overall survival benefit. But surely the doubling of the overall survival by EV Pembro combination upfront is quite exciting. Do you also expect, or can you treat when you request this treatment with the payers? Do you expect to have it approved in your country as well?
Yeah, I think we are waiting as you in EMA approval, and probably in a year more or less, or a year and a half, we can have the price reimbursement for the combination. The fact is that I'm not pretty sure which patients I'm treating with cisplatin gemcitabine nivolumab, because I do believe that it's an important combination, that the median overall survival is high. We're talking about 25 months. The recent data from ASCO talking us about the benefit of those patients with only lymph node disease, with that high response rate, that PFS and overall survival curves showing that probably is the subgroup of patients which have more benefit from this combination, could have a role in our daily practice. So probably we will have a dilemma between choosing, if we have the possibility, Javelin, Checkmate, EV302 possibilities.
Well, thanks for sharing those important insights, especially on the just recently released data from the combination nivolumab trial. So fully agree. You mentioned you look at the patient and see if they are cisplatin eligible or carboplatin. Sometimes they have such a frail situation that you cannot offer neither of them. Do you still see a role of IO monotherapy, for example, pembrolizumab or nivolumab, or atezolizumab at the beginning?
Yeah, of course. And based on GAPTA criteria, there are patients who are not platinum eligible. But the fact is that we have the results from these two phase 2 trials with atezolizumab and pembrolizumab offering response rates and median progression-free survival of 11, 16, median overall survival. But the fact is, in Spain, we don't have price reimbursement for these two drugs. So we cannot offer our patients this combination. And those patients we think are not available to receive cisplatin or carboplatin gemcitabine schedule and need to be offered probably palliative care or another schedule gemcitabine, but not monotherapy with IO, because, as I have said, we don't have price reimbursement for these drugs in this setting.
Okay, that's a pity, but I mean, in optimal world situation, you would consider this. And what happens in this case? You mentioned Optimally, you have response on platinum, then you give avelumab as switch maintenance concept, what we learned and what works pretty good, and has shown pretty durable overall survival data of up to 40 months when you have a good response. So the question is, if you have those 20% progressing patient on chemotherapy, what's your next step? Is it like the pembrolizumab as next step, and this is then reimbursed?
It's not, you know that we have to phase 3 trials after progressive disease, after platinum gemcitabine schedule. We have the atezolizumab trial in vivo, which didn't show benefit in overall survival, and the keynote with pembrolizumab having some benefit in overall survival, but we don't have price reimbursement for pembrolizumab. So we treat all our patients who progresses after platinum gemcitabine with atezolizumab nowadays.
Okay, that's Enrique Grandes data he published, and it was quite good. But according to EU guidelines, I think preferred option, also the German guidelines say this would be pembrolizumab. So what's next then? And what other factors? Do we have biomarkers we can use in clinic in order to maybe have a tailored approach in advanced urothelial carcinoma? There was also a lot of discussion at ASCO and ASCO GU. What's your biomarker you like to use in urothelial carcinoma?
Probably after patients have progressed to cisplatin gemcitabine and IO, we need to test FGFR in order to offer erdafitinib based on the third trial, the cohort 1 showing a benefit in front or opposite to vinflunine or docetaxel. We have learned that Nectin-4 is maintained over the time, but probably we are learning that the amplification matters and not only the expression. And we have a lot of hope with sacituzumab govitecan with the TROPICS trial, but you know that we have a press release a day before ASCO showing us that the study was negative. So TROP2 is a maintained biomarker expressed all over the time in metastatic urothelial carcinoma, but the study is negative. So probably the data of the sequence of the TROPHY trial phase 2 showing that sacituzumab have activity after enfortumab, and the real world data of USA showing this activity, it's not enough, and probably the drug is not gonna be reimbursed in our setting.
Also, with regards to the already existing approval and data from the EV301 trial, we have monotherapy approval, and here it works. So I fully agree. I had also the impression that was quite disappointing to look at the SG activity. I mean, we haven't seen the data in detail, but press release speaks for itself. So thanks for your expertise. And as you said, FGFR inhibitors is an option according to the third trial data in third line. Also, PD-L1 has some prognostic effect, but it's not really that helpful in the clinic, just for some settings in the adjuvant situation. So how do you, like, let's speak a little bit about safety and adverse event management when you give upfront chemotherapy. Maybe this topic, switch maintenance. Do you switch after 4 cycles, after 3, or you full cycles of 6 cycles chemotherapy, like in the Javelin Bladder 100 trial? And we have seen some data that it's also possible to switch to avelumab after the 4th cycle. So is it depending on the toxicity of the chemotherapy, or what's your approach?
In the majority of patients, I'm switching to avelumab maintenance after 4 cycles of cisplatin gemcitabine, and only in a few patients with PD-L1 negative. We are not determining PD-L1 as a routine, but sometimes we have the information from other times. Only in that patients I continue to 6 cycles, or those with visceral metastasis with a great response after 4 cycles. I prefer to consolidate the response until 6 cycles. But in the majority of patients after 4, I perform a scan. And if there isn't progressive disease, probably in a month, more or less, I'm starting avelumab maintenance.
That are very good considerations. Especially, I like this fact you just told us. with good responding visceral metastasis like liver metastasis, lung metastasis, where you know, according to the Belmont criteria, the prognosis is really, really bad. So if you have a response, maybe it's very smart to go for the 6 cycles and then go to avelumab. So post-avelumab, do you see any use of platinum rechallenge in case of situations or countries where enfortumab vedotin or other drugs like erdafitinib are not reimbursed?
I asked this question to Tom Pauls in a meeting we had because I didn't know the response rate of cisplatin gemcitabine offered as second-line treatment or after Pembro AV or as a rechallenge. And he told us about, I don't know where the information was, but he told us about a 20% of response rate was expected with the rechallenge, which is inferior to offer erdafitinib or enfortumab in case they haven't received it before. Said that, I have retreated patients with cisplatin gemcitabine with not an excess of the peripheral neuropathy, you know, but it's not my preferred sequence.
Okay, well, thanks. Finally, just because we have this drug in Europe approved, vinflunine, is there still a role of vinflunine? And also, we sometimes used historically paclitaxel in metastatic urothelial carcinoma. What's your word on that?
I think I love vinflunine. I use it a lot of times with all my patients before having the approval for enfortumab. And I think now its role is after the third line, probably. The fact is that only 15% of patients will achieve this fourth line. So I don't know specifically the road this drug is going to have, but I think it's a useful option for some patients.
Good. I think also it's good not to forget about it, since it has some activity, and as said in Europe, it's approved. Paclitaxel also, but I think we have more modern options now for our patients. And as you said, there are rarely patients getting into fourth, fifth line of treatment, but they are, and sometimes they benefit. So Maria, we have all those great new options now. So, however, it sometimes can go along with some price, like adverse events and side effects. And we have a lot of educational activities we also did together at symposiums and conferences. So you have, I know, a lot of experience with treating patients with enfortumab vedotin, for example. And what is your advice to the listeners on side effect profile? What would you comment on that?
I think we need to visit the patients, to take care of them, to ask them about the side effects in each visit. We cannot prescribe the drug each 3 weeks, you know, because you need to ask about peripheral neuropathy and the skin adverse reaction. But in my daily practice, I can say that we have treated 35 patients with enfortumab vedotin, and only less than 5-6% of them developed peripheral neuropathy, and it was stopped in a grade 1-2 when we detect it, so we can reintroduce the treatment in and a half of them, more or less. And on the other hand, with other drugs as avelumab or other immunotherapies, we have a lot of real world experience, and we haven't a lot of problems. It's a drug that is very manageable, and it's easy to offer to the patients and to control the side effects you can have.
Good words. And I think, like in EV, you see the patient anyhow pretty often with this weekly dosage. And I think that's important, that they are seen not only by dedicated nurses, but also by the doctor to double check. Timing wise, when do you expect, or when would you advise us to look for side effects? Is there a time, like after 2 months or 6 cycles, where you would not be where there would not be a lot of more side effects, or can this happen even after half a year?
I think the skin reaction are expected to happen the first 2 cycles, and the peripheral neuropathy probably in the first 3-4 cycles. But you can be aware of them probably all the treatment you have with the patients. The median expected of treatment is in the trial was 5-6 months for EV301 and 8 months for pembro enfortumab. So probably you need to take care of them continuously and ask for the side effects continuously. But you are right, the first months are critical.
Okay. And then we can still like do dose reductions or interruptions to help and support and involve other specialties like dermatologists and so on. So I think it's important, especially like in this this multidisciplinary treatment setting, to involve all the colleagues and have good eye on the patients. So having you now for just some more minutes, I would love to ask you, what is your perspective for the next couple years? What can we expect on interesting data at the big conferences, or, as we said, press releases? Where would you say, hey, Axel, have a look at ESMO, ASCO next year, ASCO GU? There's some exciting coming up.
Probably we are going to listen about sequence treatment in metastatic urothelial carcinoma. Probably we are expecting the publication and not only the press release of the trophy trial of sacituzumab govitecan opposite to bimflurine and docetaxel. Not only ADC, but also other ADCs which have not been mentioned as anti-HER2. Probably trastuzumab deruxtecan in combination or in monotherapy are going to show the results. In the perioperative setting, I want to know about the keynote A66 in order to think if we are over-treating those patients with a TIF-PT0 after neoadjuvant treatment with pembrolizumab plus chemotherapy, and we are offering them a whole year of adjuvant immunotherapy. Probably the 905, which has been closed recently with pembrolizumab in the neoadjuvant setting, completing 5 cycles of enfortumab after the cystectomy and over a year of pembrolizumab. So I think the landscape in urothelial carcinoma has started, and probably the next 2 years we are going to have a lot of news about that.
Well, thanks a lot. And I think also this is the most important game changers possibly, especially in the perioperative setting when you give, for example, an ADC and IO treatment upfront. This very much influences how we treat later in metastatic disease, and surely involves us as urologists being involved in the surgery of the patient. Ideally, in the future, maybe we can spare the surgery and bladder preserve, but we're not quite there. But this would be also my exciting thing I will look at as a surgeon. What about bladder preserving in the future? So again, Maria, thanks a lot for all your expertise, and I'm really looking forward to seeing you in person again at probably ESMO Barcelona in this year.
Thank you very much, Axel.